Good evening, afternoon, and whatever, wherever the sun lies, wherever you're in the world. We now continue with the sixth edition of this eighth event of the Critical Lung Day. We're following one of the mechanical ventilation series right now, and we will be discussing controversies and debates in mechanical ventilation. So we have known the physiology for some time now during undergraduate and graduate studies, and sure, the knowledge has improved quite a bit. However, a lot remains to be discovered. There's still plenty of controversies regarding criteria, markers, and especially when we talk about the critical patient, we must make the best possible decision at all times. For that reason, we have to be very aware of all publications and all our options. So now we are going to hold discussions with many types of experts. We will have a session in which we will have three different sessions, and we will be discussing what our main questions are and what we're still missing. So first of all, I would like to thank you all for being here, and for continuing your education. It speaks to your character and to your commitment to your patients. I would like to thank the organizing committee for doing all of this wonderful work to disseminate this knowledge everywhere in the world. And finally, all the speakers who have brought all of their knowledge and experience and who have generously shared it with everyone. I would like to now introduce to you Dr. Enrique Monares. Dr. Enrique Monares is a specialist in critical medicine, honoris causa doctor for his contributions to critical medicine, a member of the National System for Researchers. He has a title in the ABC Medical Center, of which he graduated with high honors. He is the current head of obstetric ICU at the Health Secretariat office in Mexico. He also has a critical medicine specialty from the Autonomous University of Mexico, a well-known physician in many congresses with a myriad publications, who will today be speaking about lung recruitment maneuvers. Should they be used routinely, or should they be used only in special situations? So, without further ado, Dr. Monares, please share your presentation with us. And please proceed with your talk. He is currently is feeling a little under the weather, and yet he is still to share it with us. Enrique. Yes, thank you very much. Everybody can see my screen, is that correct? Yes, Enrique, great. All right, wonderful. So, first of all, I want to thank you for the invitation. You were very kind to introduce me. My name is Enrique Monares. I'm an ICU doctor. We want to thank the organizers. So I would like to leave you with my contact data in social media. And I am so happy to discuss any issues on critical medicine if you'd like to discuss. And I have no disclosures to declare. It is a true privilege and honor to be here with you. We'll be discussing alveolar recruitment maneuvers. And likewise, or rather, I would like to talk a little bit about the past. Keep in mind, please, that everything started with maneuvers back when the first ventilators allowed for the possibility of do a SILI-like recruitment, right? Following the tradition of anesthesia. They were using the ambu bag, the insufflation bag, to do recruitment maneuvers. They were called SIs back then. They noticed it worked quite well in the OR to improve oxygenation, to improve atelectasis, and to facilitate extubation. And so ventilators started developing, including these modalities so you could program that. In 1998, I was told that the machine absolutely had to have programmed sigh breathing. And for ventilators that did not have this modality, we would have to go every hour or every 2 hours to do these maneuvers. So I will now do a physiology recount, a physiology summary, considering that now we are among a crowd of very educated professionals. we're not going to do the math. We are going to go straight to the evidence. The question is whether we should still do SILI-like breathing to do alveolar recruitment maneuvers in an acute setting where the clear answer from meta-analysis is no. However, everything comes from the fact that we assume that the laws for alveolar protection endure. The arsenic weight, which only, and honestly, only very few patients are ventilated according to the arsenic protocol. That includes current low volumes and pressure under the volume of 30. Those are the main situations. So there are some studies that speak on the fact that a acetylglycanol, a flatlining could actually improve recruitment. But essentially, we have two types of patients. So the reason for flatline pressure is being 27 centimeters of water. That's because it's 25 millimeters of mercury, the maximum pressure that the right ventricle can endure. As we move away from 27 millimeters of mercury or centimeters of water, we started causing a corpus pulmonale due to lung overexpansion. But it's also true that if the alveoli collapse, we're going to have lung hypertension induced by this collapse. That is, collapsing and overexpanding the alveoli will cause corpus pulmonale. If the alveolus is collapsed, we will have hypercapnia with low current volumes. If our positive pressure is too high, we're going to have lung hypertension caused by corpus pulmonale. So many times due to high pressures. But we could also have it due to very low pressures in situations of alveolar collapse. So in this way, the flatline pressure that needs to be maintained in the right ventricle, well, this pressure needs to relate to the function of the right ventricle. Once our parameters are set, the right ventricle should be in an optimal condition. And if we were to do any alveolar recruitment maneuver, whether it is through SILI-like breathing, and we're going to do this, or in maneuvers that are not recommended still. And finally, a mild recruitment maneuver. Do not lose the potential for recruitment in the patient, but all of this is assuming that you are monitoring the right ventricle at all times and you make sure that there is no corpus pulmonale. If you do have corpus pulmonale, you must make sure that our mandatory ventilation management does not have excessively high parameters. Because if we induce corpus pulmonale induced by the ventilator, much like you see in this image over here in cardiovascular intervention, well, this is a very difficult, dire situation. We must understand that the energy applied by the ventilator upon the right ventricle and towards the lung, the more energy is applied through mechanical pressure. I'd like to just remind you that for the longest time, we have called this mechanical power. However, that's a poor translation. The correct translation of this formula is potency, mechanical potency, the work done. The more potency, the greater the chance of developing corpus pulmonale. And if you realize, the numbers in mechanical potency are actually quite low. In that sense, if the potency is under 10, now the ventilator is causing some damage upon the right ventricle. And therefore, there is no single alveolar recruitment maneuver that is totally safe. At some point or another, all will harm the right ventricle. Therefore, we must consider whether there actually is any population that we could identify that could benefit from size, solid temperature, or from recruitment. Because maintaining pressures north of 8 or increasing 20%, and this is the famous recruitment maneuver that is done with the ventilation bag, this is enough. And obviously, these maneuvers can open up the lung, but they are enough to compromise the right ventricle. And I would like you to see also that the healthier the lung, the greater the chance of having an increase in energy in a recruitment manner compromise and increase the mortality for the patient. If a patient would have an O2 pressure under 5, or with a mechanical potency under 10, the mortality is quite high. If we're ventilating at a mechanical potency of 20 and the lung is normal at a PaO2 greater than 300, there's a 75% chance of that maneuver complicating the patient. And so, please do not do recruitment maneuvers in any patients with more than 150 of PaO2. And we have to titrate that, whether it is in the SILI maneuver or alveolar recruitment. That again, I don't recommend it in that scenario. It cannot give us a potency greater than 20 in any case. The most important lesson in mechanical ventilation, is someone who needs just a little bit of technology, some very basic skills, just some basic knowledge as well, but a lot of heart. We also have to keep in mind that we need to make sure that the collapsed alveolus or compromised alveolus, if we were to see that we have B lines, but they're separated by more than 7 millimeters, this is likely a cardiogenic edema, and we're not going to do anything there. If our B lines are under 3 millimeters, it is very likely that we have the mosaic-like glass image. There we could consider recruitment maneuver. And if we were to do a lung ultrasound and we find an intermittent image very similar to a pneumothorax, but coming and going, it is very likely that whatever we're seeing is alveolar overexpansion, overdistension. It is very different from seeing the pleural lines. As we said, here we have cardiac beats, we have heartbeats. When we look at heartbeats, this patient is in a proper perfusion ventilation ratio. If we look at the heartbeat in lung ultrasound, I would recommend the maneuvers. But the right West maneuver, in the proper West maneuver, it is not recommendable to increase the pressure from the ventilator. If there is a cardiogenic edema, this one could be fitting maneuvers. Now, if we have a patient with a PaO2 or a PaFi under 150 and a pressure under 15, if every time we increase the PEEP, the PaO2 or FiO2 increases by 25 points, this is the group with the highest survival. So if you have a patient with less than 150 PaFi levels and PaFiO2 increases 25 points with the maneuver, this is the only evidence that we find that overall survival is improved. But even in the case of patients that don't have a PaFi greater than 30, and if you have ventilations over 300 joules per minute, and we don't know 17 joules per minute, apologies, then there's a high risk of developing a lung injury due to the ventilator. This is why it's so much that if we are going to do studies on whether it is worth doing some minimal alveolar recruitment in a SILI manner in a very small number of patients, or just keep looking for patients who do benefit from alveolar recruitment, we have to make sure that it is in patients with a PaFi under 150 and that we don't go beyond 17 joules for the attempt at recruitment. This index formula based on respiratory frequency or PEEPs. It also adds mechanical potency to the patient's distensibility and a surrogate of the dead space. And so this gray area from 4,000 to 6,000 in this formula, I believe, could be the population with greatest potential benefit from the increase. If we have 3,000 or less, then this lung is definitely healthy, and I would not like to intervene at any point. If we are above 7,000, then this lung is severely injured, severely damaged. Recruitment would not be a good idea. Now, we also have to consider who exactly we want to recruit. If we have a patient with a distensibility under 25, the main mechanism of damage is volumetric. And we find that famous flat line minus PEEP. And if distensibility is under 24, the main point of damage is caused by the volume. So recruitment in this sense would be a bad idea. If distensibility is reduced, then recruitment, flatline under minus PEEP, and new approaches could be counterproductive. So yes, we have different maneuvers for recruitment. So we have a 40 by 40 that did not involve as much volume, and that it could be a situation of a patient with more than 24 distensibility. However, for those patients under 25, they could benefit from these maneuvers in which we maintain that flatline minus PEEP relationship and in constant increases without increasing current volume. So yes, we have to find those lungs that could not benefit, but also to determine what maneuver is less harmful to the lungs. John J. Marinos recently has proposed these formulas. They're much more complicated, and it is not flatline minus PEEP and target. This is just a very complicated way of determining the target. You could say that, but if we have a target of 15 in pressure, we do have patients who could be properly ventilated with a limited volume. And we also have patients who could endure a much greater volume than we initially considered. Those are patients that could benefit from having a program that's SILI-like recruitment, as we did back in the 90s. Then we have the study from Marcelo Amato on artificial intelligence. Patients with pneumonia and with vasopressive treatment, and I'm not talking about just about pneumonia, but focal lesions and vasopressor therapy, they don't benefit from alveolar recruitment maneuvers. It is likely that the only benefit of recruitment maneuvers is in patients without focal lesions, without vasopressor treatment, and a ratio in a driver, a low ratio, and a driver pressure of 18 or less. That will determine it. And the measure of harm will depend on whether there is a diffuse injury or not. Potential damage should be measured with the Amato formula, 4 times driving pressure minus respiratory rate. However, we have to determine the mechanical potency to see whether we're applying too much energy in each maneuver. As you've seen, we have to go into much more detail into the lesion of the patient, as well as the energy applied, as well as the transfer of the energy. And finally, we are very skilled in opening up the lung. We don't even need a CT scan with electrical impedance. We see something very simple, like the oximetric leak. We see how saturation can improve in this way, how distensibility improves, and we can do this in a much more complicated way, much more subtle way, using electrical CT scan to find those recruitment spots. But the most important, in fact, you can do this with an ultrasound, and you can see what patient was successful and which were not. But the most important thing for a recruitment maneuver is not just to open up the lung, but to make sure that the lung is not overexpanded and that this lung will not collapse once again when we drop the pressures. If the lung is overexpanded or if it collapses after any type of maneuver, well, this will become completely irrelevant for the evolution of the patient. This problem has many, many different aspects, many faces, and when you have a many-faced problem, you often think that there's somebody against you or you have false information. There's plenty that we can do from a physiological standpoint and statistics for the benefit of the patient. But for the moment, for the time being, the famous 40 by 40 and other approaches are really not indicated in current mechanical ventilation. But we can find patients who can benefit from the famous SILI-like ventilation. If we do that in the postoperative period, it's likely that we will extubate the patient more quickly. And the intermediate maneuvers that allow me to see whether the patient has recruitment potential need to be explored. The easiest thing to do is to just open up the lung, but it's a lot harder to keep it open. And what is most complicated, we don't know when we're over distending. Thank you for your attention. I hope we have a lot of questions. Thank you very much, Enrique. All right, then. Continue with the next lecture.
So we have
We
Dr.
have Dr.
Fajardo-Campoverdi,
Dr. Fajardo-Campoverdi.
and professor of La Frontera
He's a
University
specialist in internal medicine.
and intensive adult medicine, and he's an expert in respiratory support and a specialist in statistics and biostatistics, a fellow in experimental respiratory physiology, and he's doing a PhD in medical science and respiratory physiology research. He's chair of WeVent and works at the Bioprovincial Quiotoa Petorca, Chile hospital. So next, Dr. Audio Fajardo's talk. Good afternoon. A very fast update I'm going to present on the damage induced or associated to mechanical ventilator. I'm Ala Fajardo. I greet you from Chile. In this case, I represent also the WeVent group. And I represent all the organizations that support me, and I don't have any disclosures for this talk. So theories have appeared, and I say theories because in effect, there are no clinical trials that support this hypotheses associated to barotrauma that or volutrauma that after time have been appearing, and we have tried to understand, but also trying to somehow manage them and avoid generating greater harm to patients that have a requirement of invasive respiratory support. So then a biotrauma or atelic trauma started. And then after 2016, we have the ergotrauma. Many of my friends, the Spanish team and my team, think of a very important hypothesis on looking at exact science that look at rheology and material engineering, and something else that we're thinking with our group that is called energy transference, which demands that we think and see if we're talking about harm induced directly or if it's associated to an incapacity of understanding the form in which energy is transmitted and in which it's dissipated as well, and it is absorbed or transformed, respecting all the basic concepts of material engineering, but basically physics as an exact science. So what we suggest in the Journal of Mechanical Ventilation the previous year was that we believe from our perspective that we are before the presence of damage that is associated, harm that is associated and not induced. We have the first value, the driving pressure. And it's very clear there's evidence that is interesting and important, like a first parameter that allows us to have certainty with regards to values on which we should not look at the static mechanics of our patient. And we would be reducing the probability of generating more harm associated to this mechanical ventilation that, as I mentioned before, we call it transference of energy. And it is because the driving pressure, beyond being a very interesting concept and easy to understand clinically, it's interesting because all of the evidence that comes from Dr. Amado has allowed us to understand that values under 30 centimeters of water of plateau pressure and thus driving pressures of 15 centimeters of water give us a certain amount of range of certainty that makes us feel calm when we ventilate our patients. But the other thing that is open to us is the PEEP pressure that with certain analysis, thinking of several models where we test the efficacy of the driving pressure, and there's not much discrepancy on the concept is related to the amount of PEEP required for each pathology and each patient with regards to individualization to try to reduce certain values associated to a static measurement of the values we have already mentioned. So a first pillar so that it clears the driving pressure and not a lot of discussion. And then in the era of transference of energy, we have a first concept called the mechanical power, more geometric and mathematical preciseness, where we have been affirming over time, and we have learned that the tidal volume is involved, and we have known values that of the 6 ml per kilo for patients in distress. And also we just mentioned the driving pressure. But there are two very important values, not out of the equation, but very underestimated, such as the PEEP and the respiratory rate. And in that context, there's very interesting work headed by Alejandro from the Spanish team, where in a retrospective study, they compared patients and in 4 groups. Number 1 are patients, normal patients, no hypoxemia, and they're not obese. Group 2, patients with severe hypoxemia, but that are not obese. Group 3, patients without hypoxemia, but that are severe obese patients. And group 4, patients with both pathologies, both severe hypoxemia as obesity. Why is this work important? Why do I bring it here? Because it allows us to see the amount of energy with regardless of the weight, applying the known formula of the mechanical power was not statistically significant. It's not the only work. So we can conclude, and it leads us to think that the hypotheses of mechanical power, beyond being a firm theory that is generating a lot of evidence, is related to the fact that we still need additional things so that it is more complete. So our work on the mechanical power, applying the formulas, the corresponding formulas, is the transfers of energy is related. And the first plays to the ventilatory mode. In this work, we show the mechanical power in a multicentric study. So this control is associated to more transfers of energy. Then in 2023, in the Journal of Mechanical Ventilation, we showed the other part of these variables that I just mentioned, inspiratory rate in these patients that were monitored, and we set the PEEP through a transpulmonary pressure catheter, esophageal catheter. In all the models we created, both in the baseline measurement at 30 minutes and after 24 hours of sealing this PEEP, always within static values and normal ranges, the inspiratory frequency was not over the rest of the variables, so that we were able to see that it's relevant, that we need to consider it, that it cannot be out of the equation. And we verified this in the mechanical power data, where we're suggesting the elevated frequency trauma. And through statistics, we showed that the respiratory rate had the highest risk of association with distress. So stepping out of the evidence generated by a group, this interesting group presented in 2023 by the Journal of Intensive Care that includes patients with COVID. Well, we have the component, the respiratory rate with the McFadden test that is related with a high risk of being associated to generating more transfers of energy in the context of distress. So as we can see here, the PEEP is outside of the equation again, followed by a driving pressure that is secondary to respiratory rate. And this is interesting because there was another meta-analysis that includes relevant work such as the Miade or Talmor, Mercat, and Carl Hudson, looking at the PEEP. And very well done work with low heterogeneity. These are clinical trials. An elevated PEEP was related with an interpretation with regards to the reduction in the transference of energy. And a meta-analysis headed by the Spanish team. Once again, they showed that PEEP has interesting relevance with regards to transference of energy and the mechanical power. In this case, they showed that stress was related to a set PEEP. And if this is translated as something over 160, was not necessary to go on to determine whether to go up or out with regards to up or down with regard to PEEP. So it was personalized setting. And if we were able to do, and we had a PAFI over 160, well, the patient needs more time. A reminder of the geometric and mathematical formula of the perception of mechanical power, we can see that the elastic static component is outside of the equation, both in volume control as in pressure control, and that this could underestimate the transference of energy because after this, there is dynamic insufflation. The dynamic part is more than clear, and Brochard showed that it's correlated with a higher risk of generating transference of energy. But Amate Costa showed in this interesting work from 2021 that with regards to PEEP, there's an elastic static component that cannot be outside of the equation that is very relevant. Besides the other variable that I come to defend with it is the respiratory rate in the parameters that we need to watch out for besides the driving pressure to minimize the risk of harm associated to ventilation. And in this work that is about to be published in intensive medicine in Spain, we see the total elastic power that has a group that supports this hypothesis where we measure the elastic static power, and we conclude that the elastic static power in its factor of conversion to joules per minute was associated with the development and the presence, mainly the presence of distress, both mild, moderate, and severe, in this post hoc analysis that we did of mechanical power. And other variables like the elastic dynamic power, the resistive power, and even the mechanical power when we correlated it. So the conclusion is that beyond the classical values that we know of, there are equations that we have called, or that take out of the shadows static variables and include them as parameters or safety ranges that we have to consider to try to minimize the risk of harm associated to mechanical ventilators. These are our social media for any doubts, and we are happy to receive questions. Thank you. Excellent presentation from Dr. Aurea Fajardo. Next, I would like to introduce Dr. Alexandra Matilde Saranguro. Dr. Alexandra is a specialist in critical care medicine and intensive therapy with studies in promotion and prevention, chief of critical care medicine and intensive therapy from Hospital Atacunga in Ecuador. She was the director member of LADIC in 2022 to 2023, member of the Mechanical Ventilation Committee of the Pan American and Iberian Federation of Critical Care, Intensive Care Medicine. She will talk about how to differentiate between auto-induced pulmonary lesion and diaphragmatic dysfunction induced by ventilator. Dr. Alexandra, the floor is yours. So mechanical ventilation is in essence a support that saves lives. As I had mentioned, it improves oxygenation so that we can solve the primary cause that has led the patient to that need for mechanical ventilation. So in reality, at least we consider that 1/3 of patients that go into intensive care therapy require this support naturally. In the last 20 years, approximately, a lot has been studied about mechanical ventilation. We have several guidelines about how to be able to manage several aspects, even on ARDS. But we have to do more research, even more so considering that we still need interesting data that can be rescued. So in this slide, I will talk about how SILI, or self-induced lung injury, is produced. Mechanical ventilation, for a couple of years, Yoshida presented information on how inspiratory effort, high inspiratory effort, is accompanied by a non-homogeneous distribution of transpulmonary pressures that go all over the lung. So during inspiratory effort, considerable inspiratory effort, pleural pressure produces an increase of the transmural pressure of the vessels and muscular patency and favors pulmonary edema. And with that, naturally, that inspiratory effort produces excessive tension that leads to a risk that the tidal pressure administered by positive insufflation from a respirator can injure. So that is basically what happens in that self-induced lung injury. As a second point, these oscillations in transpulmonary pressure generate high volume insufflation in a compartment that is reduced because of the loss of volume because of ARDS. Besides that, there's also contraction of the diaphragm because this generates heterogeneity, and there's displacement of tidal volume between pulmonary areas that are non-dependent from the dependent ones, even from the moment from the inspiratory effort. So there's increase in cyclic inflammation and exposes other dependent regions to be exposed to volotrauma and telic trauma. Now, as we see on this slide, this is a study done through simulation where they applied in a patient with pressure support with a PEEP of 5 and a support pressure of 10 centimeters of water. So if we look at the part that says A in this part, this is inside the tidal volume that was inside the normal clinical ranges, and alveolar pressure was generally over the PEEP, unlike the B figures. In B and B column, there's an important reduction, as we can see in the red lines, which is a reduction of the tidal volume and a drastic fall of the alveolar pressure, very much under 0 centimeters of water. And so there's a higher risk of ventilator-induced harm because there is an intensive inspiratory effort, alveolar fall way beyond zero, and it leads to similar tidal volumes and pressures that affect all of this area of the lung. So something that is very closely related, as I just mentioned, is that in the end, what happens with this is that the diaphragm can become harmed because of this inspiratory effort and because of the development of excessively high mechanical forces throughout the muscle. And in this case, there will also be a ventilation induced by diaphragmatic dysfunction. And from the beginning, since 1988, SILI did a study where he showed that there was thinning of muscular portions of the diaphragm in neonates that underwent long times of mechanical ventilation. In that sense, and after that, we have been seeing that in these last few years, there's more interest about researching what is happening in the diaphragm and how it starts to become damaged. There are studies that show that even after 18 hours of starting mechanical ventilation, there's already a compromise. On this slide, I'm showing you the terminology that exists because it also shows diaphragmatic weakness related to the critical patient's weakness. A ventilator-induced lesion at a diaphragmatic level is a phenomenon that is characterized by a loss of capacity to generate force that is associated specifically to the use of mechanical ventilation. In fact, the resistance of the diaphragm reduces in up to 40 to 50%. So there are studies that even after very few hours, there's already this compromise. The mechanism through which this damage is produced, it can be acute respiratory failure, and there can be other pathologies such as cardiogenic shock that since there's no or low cardiac output, it will affect blood flow. And the diaphragm has to go to an anaerobic metabolism, and there will be production of high muscle lactate. Sepsis, as we can see, also is closely related in two levels. First, it can be because of alterations in different steps of the supply chain of muscle energy, and also because of the direct decay of contractile proteins that results from septic mediators such as cytokines, necrosis, tumor necrosis factor that produce harm at a diaphragmatic level. Naturally, sedation, because in that sense, we have a reduction of the diaphragm's capacity to generate pressure in the long term that harms all the work of the diaphragm. As I mentioned, even a very few hours after mechanical ventilation is started, we have a certain degree of atrophy and a reduction of the contractile force, which has been shown both in vitro as in vivo. And in some studies, as I just mentioned, we have seen that there's a relationship with the activation of proteolysis, the mitochondrial dysfunction, and oxidative stress. More than mechanical ventilation in itself, it's the discharge of the diaphragm under mechanical ventilation that contributes to that weakening of the diaphragm. As we can see here, over respiratory over assistance, even though it hasn't been demonstrated that it has a direct relationship with the risk of SILI that I mentioned before, but it can expose the diaphragm to eccentric contractions that can be potentially harmful. When we reduce or when we end that inspiratory effort, it is affected as well because there's a sarcomeric disruption and there could be contractile fatigue. And the case of eccentric myotrauma, that also affects, and it could also affect and it could generate regional distension. Another important factor that is also related to the diaphragmatic involvement is the patient's synchrony with the ventilator. In the majority, they are related to premature cycling and an inverse trigger. In terms of the impact on clinical outcomes, we have seen that it makes the weaning difficult, 25 to 63%, depending on the method used. You can verify that the diaphragmatic pressure is affected when it's taken as a cutoff point with 11 centimeters of water. And the respiratory muscles are affected up to 7 days after the discharge from the intensive care unit. Here you can see everything we can do to assess diaphragmatic function. Transdiaphragmatic pressure is the gold standard in reality to assess the force of the diaphragm. It does not depend on the patient's effort. But as you can see, it is difficult, it is complicated sometimes to be able to achieve all of these points to monitor diaphragmatic function. That is why lately, as you know, we can advance with a diaphragmatic ultrasound. So it's important to highlight that even though this is not a method to make decisions on whether to move forward or not with the weaning, this method is useful to be able to know its tolerance. This can be done using two windows, the subcostal window and the intercostal window. As you can see, the first one is in the clavicular midline, perpendicular to the dome, where you can find the abdominal or the cardiac images. On the graphs, you can do this on the M mode, and you can assess the expulsion of the diaphragm and see if there's adequate respiratory drive. And the intercostal window, that is done at the anterior axillary level between the 8th and the 11th rib. It can be done with a linear transducer. The width has to be measured in M mode, and we can do it at the end of the inspiration or at the peak of inspiration with a calculated fraction of the width of the diaphragm or the thickness of the diaphragm to see how the weaning will go. On this table, we summarize many strategies that could be used, but both studies in animals and clinical research, recent clinical research suggests that maintaining spontaneous respiration under mechanical ventilation should minimize diaphragmatic atrophy. However, as you know, in some cases in patients with ARDS, the use of sedatives and neuromuscular blocking agents, because as I had mentioned, those can also generate weakness at the level of the diaphragm. On this slide, this shows how we can optimize the mechanical ventilation, consider everything that I just mentioned to avoid the SILI or the VILI. And I would like to think that personalizing mechanical ventilation based on physiology and pulmonary morphology, etiology, the images that we have and the phenotypes, we should understand that as titering and close surveillance of physiologic images. Like with every single work, we always work as teams. This is my work group. And I thank you all. I have my email here if anybody wants anything from this presentation. Thank you very much. Thank you, Dr. Saranguro. So we have received these talks from the three experts on these different topics. And in medicine, there's also always discrepancies. Ever since we start studying medicine, 2 + 2 is not always 4. And in critical care medicine, well, even more so. Dr. Enrique spoke about his topics, mathematical topics. So he has a way of accessing medicine and criteria in a very interesting way. Many think that we don't use mathematics in medicine, but Enrique shows us that knowing how to use it, it is very useful. Enrique, I know that you already spoke. Seeing the questions from the attendees. If you have any doubts, you can write them now so that we can discuss them during these last few minutes. And in the meantime, I would like to ask a question.
Also, audio had a health problem. And thank you for being here because you have been sick. And there is always a chance of supporting and contributing with our colleagues and the patient. Enrique, I have a question for you. I know that you already mentioned some issues and you gave your point of view and evidence. So, what do you believe is the easiest way, or let's say more effective way, to determine if a patient is going to benefit from a recruitment maneuver? Sorry, Dr. Enrique, we cannot hear you yet. I think your mic is off. Sorry. Can you repeat the question? Of everything that you said and the evidence that you showed and the way analyzing a patient with respiratory distress, what do you think is the most effective way to determine if the patient is going to benefit from a recruitment procedure? We have called it a slight procedure. We could measure the recruitment index with the formula. And if the patient is a good candidate, maybe increase the median pressure 5, 10 centimeters of water and a slight recruitment procedure to increase momentarily the inspiratory pressure and having a control of the volume. And then we can check the recruitment index. If the patient improves, then he may be a good candidate. This can be done with patients with less than 150 PaO2 and have all the alveolar protection. We can also do impedance and Brochard formulas with a slight maneuver. Is a good way to test and see if he's a good candidate. We sometimes do not know if we are over distending the maneuver and that he will collapse the lung later. So we cannot be empiric. We need to understand who will be benefited, and we have to be careful with the over distension. And with the Brochard formula is a good approach. Thank you, Enrique. We have a question here from Hector. Patient with severe lung damage, the protection measures are recommended. But others that have a milder damage and have a rigid lung, what is more beneficial? To start with protection lung measures, because we have to use what is best for the patient. I've had a little bit of experience in trauma. I worked for a couple of years there. And I believe it's a little bit different when we have trauma and now not pneumonia. But if we can ventilate in a safe way at 6 milliliters, and nobody's going to get complicated. Beep whatever you want, but you have to be close to 6 per kilogram and keep the pressure below 30, and the patient is going to be good. Trauma or not trauma, you should start alveolar protection since the beginning. Alejandro, Dr. Saranguro, about the diaphragm, what do you believe is the best evaluation? Because ultrasound is most accessible. Well, according to studies, the best to evaluate the diaphragm is to calculate the width. We have to use the V mode at peak of inspiration, and we subtracted from the end of inspiration and multiply it by 100. In this range, we could predict the weakness, because if it's less than 20%, it's weak. Because this measurement should be a predictor so that a patient will tolerate spontaneous breathing after extubation. If it's less than 20%, it considered that it will have weakness of the diaphragm and will require more physical therapy and other techniques to strengthen this diaphragm so the patient will tolerate extubation better. So that's greater than 20%? Yeah, it's more possible to succeed. Aurel? You that you know a lot about physics and the interactions, we know that air follows the laws of Newton. But when we have surfactant in the alveolus, it's a non-Newton fluid. It's a complex situation. It's still a theory. And the way we measure the interaction with the current models that we have nowadays, maybe they're not enough. Even complex models like Kelvin Wack, we have in series and in line, and other models. Maxwell, for example, maybe they're not enough because Maxwell is not good for dynamic behavior. A situation different from the controlled studies. And a more advanced one is the one that we are proposing, Kelvin-Watt, or center and anti-center. They could have a larger capacity to measure, to transfer the energy between non-Newton fluids and Newton fluids in the alveolus. Yeah, there's still room to research, and there are discrepancies and controversies, mostly on critical patients. Thank you so much for your participation. Thank you for those that have been here. Now we're going to have a 40-minute recess, and then we will resume the session. We continue with an update in pneumonia. It's the 7th session, and we have 9 in total. Thank you so much to all of our colleagues, to our audience, to the speakers, and I hope I can see you again next year. And all of these events and the group of the groups of critical care worldwide. Thank you, Distribuna, for your support in all these training and sharing congresses, and to our sponsors, of course. Thank you and good afternoon or good night.